Hello, this will be a lecture of chapter 25, which begins on page 377 in the textbook. We're going to start with figure 25.1, which is the anatomy of the eye. This again is detailed on page 377 in the textbook. We're going to start with the anatomy and physiology of the eye. First, we'll look at the cornea, which is the clear or transparent outer window of the eye. The sclera is the opaque white portion around the circumference of the cornea. The conjunctiva is the thin, transparent layer extending from edge of the cornea to cover sclera, also lines inside of the eyelids. Figure 25.2, the eye is a camera. This is on page 378 in the top left corner. The iris and this is back on page 377, is the colored disc visible through the cornea. Pupil is the opening within the iris. The lens or crystalline lens is located directly behind the iris, and the retina is the sensory tissue that lines the back of the eye. Optic nerve is the visual pathway by which electrical impulses move from retina to the brain and back. Macula is the small yellowish area in retina that provides the most central and acute vision. The vitreous humor occupies about 80% of the interior of the eye. It is composed mostly of water. The choroid is the layer of nourishing blood vessels between the sclera and the retina. Extraocular muscles regulate the motion of each eye. The medial lateral rectus muscles, superior inferior rectus muscles, and superior inferior oblique muscles come into play. So how the eye works. Vision occurs as light waves reflect from an object, enter the eye through the cornea, then through the pupil. Light waves converge first at the cornea, then are further focused by the crystalline lens to a nodal point or N located on immediate backside surface of the lens, where image becomes inverted or turned upside down. Young eyes can modify their shape to change focus from far distance to near distance. Light progresses through the vitreous humor, then back to a clear focus on the retina and macula. Ophthalmic products. This is diseases of the eyes, which is on page 378. So some side effects are usually minimal, but may include localized ocular toxicity and hypersensitivity, including eyelid itching and swelling and conjunctival redness. Ophthalmic products must be sterile, pH balanced, clear, and particle free. They are typically used for dry eyes, infection, inflammation, and allergies. Eye infections and pharmaceutical treatment. First thing we're going to look at is a stye or hordeolum. This is a localized infection of the sebaceous gland in a hair follicle at the base of an eyelash. If deep, it is called that word that I'm not going to say, or internal hordeolum, and sometimes accompanied by conjunctivitis and purulent drainage. Treat with anti-infective eye drops, warm or cold compresses applied at 10 minutes per hour or 20 minutes 4 times per day. So this is usually caused by Staphylococcus aureus and Staphylococcus epidermis. Antibiotic therapy, likely to be a 10-day course of dicloxacillin, 250 milligram by mouth every 6 hours, erythromycin, 250 milligram by mouth every 4 times a day, tetracycline, 250 milligram by mouth 4 times a day, amoxicillin, 500 milligram by mouth 3 times a day. So blepharitis is inflammation of the eyelid margins, accompanied by redness, thickening, and possibly the formation of scales and crusts or shallow marginal ulcers. Acute ulcerative blepharitis is treated with antibiotic ointments for 7 to 10 days, such as bacitracin, polymyxin B, and gentamicin 0.3% 4 times a day. Seborrheic blepharitis treatment with improved hygiene. Use diluted baby shampoo to clean the eyelids and remove greasy buildup. Meibomian gland dysfunction or meibomitis. Treatment: use oral antibiotic doxycycline 100 milligram by mouth twice a day over 3 to 4 months, tapered down over the course of therapy. Conjunctivitis. Acute or chronic inflammation of the conjunctiva caused by a virus, bacteria, allergy, or irritant, wind, smoke, or snow. 4 major causes are allergies, bacteria, viruses, and chlamydia. Can accompany the common cold and exanthems, such as viral rashes, such as rubella, measles, chickenpox, varicella, and mumps. Allergic conjunctivitis or red eye is caused by hay fever, dust, mite dander, or animal dander. It affects both eyes, itching, swelling, and tearing. It's seasonal but not contagious. Bacterial conjunctivitis, this is page 379, starts in one eye and spreads to the other. Thick, sticky, mucopurulent discharge that causes the eyelids and eyelashes to be matted or pasted shut upon awakening. Mild photophobia. This one is highly contagious, treated with a variety of ophthalmic antibiotics. And figure 25.3 is showing you a picture of the bacterial conjunctivitis. You see the red going on in what should be the white of the eye. And we have viral conjunctivitis or pink eye. This has a short duration, usually self-limiting. It is contagious. No treatment or cure. Symptoms can be relieved with lubricants and cool compresses. If bacterial infection is suspected, treat with ophthalmic antibiotics, such as sulfacetamide sodium 10% drops or trimethoprim, polymyxin B for 7 to 10 days. Table 25.1 on page 379 details prescription treatments for conjunctivitis. And then again, there is conjunctivitis that is caused by chlamydia. This is page 380. Also called neonatal inclusion conjunctivitis or swimming pool conjunctivitis. Newborns acquire as they pass through birth canal. Neonates are treated with erythromycin 12.5 milligrams per kilogram by mouth or IV 4 times a day for 14 days because pneumonia and other complications may result from untreated conjunctivitis. Infected mothers and their sexual partners are also treated to cure the conjunctivitis and concomitant genital infection. I'm sorry about the struggle there, y'all. Azithromycin 1 gram by mouth once, or doxycycline 100 milligram by mouth twice a day for 1 week, erythromycin 500 milligram by mouth 4 times a day for 1 week. Figure 25.4 shows the development of glaucoma. The first figure there at the top is the healthy eye, flow with aqueous humor with drainage control. And number 1 in the middle there shows drainage canals blocked, buildup of fluid is beginning, and the bottom figure is labeled number 2, is reflecting the increased pressure, damaged blood vessels, and optic nerve. And that is on page 383 in your textbook. So eye disorders that affect vision. This begins on page 382. First one we're going to look at is glaucoma. This is the leading cause of blindness. Increasing intraocular pressure and decreasing outflow of the aqueous humor causes an open or closed angle. Patients with glaucoma should consult physician before taking any over-the-counter medications. Secondary glaucoma occurs as the result of an eye injury, inflammation, tumor, advanced cases of cataracts, or diabetes. Can be induced by use of drugs such as steroids, mild or severe, and may be either open angle or closed angle. Treatment would be the same as it is for primary glaucoma. Table 25.3 demonstrates prescription treatments for glaucoma. And that is detailed on page 385 in the textbook. The next we'll look at cataracts. It's on page 384. The lens becomes opaque and interferes with transmission of light to the retina. It causes causes can be congenital, such as hereditary or measles infection during the first trimester, trauma, age. 85% of people over the age of 80 are afflicted with this issue, and metabolic and toxic agents. Table 25.4, prescription treatments for cataracts, is detailed on page 385. Vascular retinopathies, we're back on page 384. Mild would include simple or non-proliferative retinopathies. This is characterized by defective bulging of vessel walls, causing bleeding into the eye. Bulging caused by small clumps of dead retinal cells called cotton wool exudates, and by closed vessels. Severe proliferated, this is labeled number 2 on page 384 towards the bottom right, is characterized by newly grown blood vessels and scar tissue formed within eye, by closed off blood vessels that are badly damaged, and by retina detaching from surrounding mesh of blood vessels that nourish it. Macular degeneration. This begins on page 386. This is deterioration of the macula, the small central portion of the eye, generally occurs in older individuals. Treatments can include anti-angiogenic drugs, laser therapy, photodynamic therapy, vitamins, and low vision aids. Psychoplegic drugs, mydriatic drugs, and lubricants. These are used in ophthalmology examinations. Psychoplegic drugs relax the ciliary muscle. Mydriatic drugs dilate the pupils, and lubricants restore moisture to a dry eye. General guidelines for using an ophthalmic product are detailed in Procedure 25-1 on page 386. 1. Wash hands thoroughly with soap and water. 2. Remove contact lenses. Wait 15 minutes after administering the medication to put lenses back in. 3. Never touch the tip of the tube to the eye or anything else. 4. Wipe any excess medication from eyelids and lashes with tissue. Recap medication container and store in a proper location at correct temperature. Wash hands immediately to remove any medication. 6. If more than one type of eye medication is used, wait 5 to 10 minutes before administering the second medication. And 7. Sometimes eye medications can cause a few moments of blurry vision. Wait until the vision completely clears before resuming activities such as driving. Applying ophthalmic ointment. This is Procedure 25-2 on page 387. So 1, hold the tube between your thumb and forefinger. Place it near the eye, but not touching any part of the eye or the eyelid. Tilt your head forward slightly. 2, with the index finger of your other hand, pull the lower eyelid down to form a V pocket. Squeeze the tube and place a ribbon of ointment or gel into the V pocket made by the opened lower eyelid. Do not let the tip of the tube touch the eye, or the eyelid for that matter. And 3, blink the eye gently. Do not squeeze the eyelids together. Close the eye for 1 or 2 minutes. And there's the figure demonstrating what they were trying to detail with the V. And again, this is on page 387 in the textbook. Procedure 25-3, still on page 387 in the textbook, is going to detail how to instill an ophthalmic solution. So you want to uncap the container, tilt head back slightly, and look at the ceiling. 2, use index finger to gently pull down on lower eyelid to form a pocket. 3, position the dropper above eye, look up and away from the dropper. 4, squeeze out prescribed number of drops and gently close the eye. 5, apply gentle pressure to inside corner of closed eye near the nose for about 1 minute to prevent liquid from draining down from the tear duct. 6, if using drops in both eyes, repeat the process in the other eye. And figure 25.6 is the figure that goes along with the instructions. So table 25.2, various topical ophthalmics used for ocular infections, is found on page 388. And as you can see, it's quite a detailed list. I'm going to let you go through that at your own leisure. And then we're going to move into the ear. This begins on page 389 in the textbook. The anatomy and physiology of the ear. Outer ear structure includes the pinna, auricle, and concha. External auditory meatus. Outer ear captures sound waves and directs them to the tympanic membranes to boost sound pressure. Middle ear structures. This is page 390. This is where the tympanic membrane or the eardrum is located. The auditory canal, Mollius incus and stapes. The eustachian tube, which connects the middle ear with the nasopharynx of the throat. Middle ear infections require immediate treatment. Inner ear structures associated with both hearing and balance. The cochlea, which is the snail-shaped organ that contains the nerves required for hearing. The vestibular labyrinth, which contains the sense organs required for balance. Complications of earwax or cerumen buildup messes with the homeostasis of self-cleaning and can be interrupted when wax builds up against the eardrum. Using cotton swabs or other objects to clean out the ear serves only to push the earwax further inside. Figure 25.7 is illustrating the anatomy of the ear. That figure is found on page 389 in the textbook. The continuous scratching of the ear canal, which has very thin skin and is easily injured, can lead to pain and infection. Hearing aids can prevent the migration of earwax out of the canal. So there are different types of hearing loss. This begins on page 391. The first that we will look at is conductive hearing loss. This occurs with problem in part of outer or middle ear. It's mild and temporary. Sensory hearing loss. The cochlea not working properly because cilia have been damaged or destroyed. This can occur in one or both ears, almost always permanent. Drug-induced hearing loss. This can occur with some ototoxic drugs, impairment of hearing and balance, reversible or irreversible. It can be caused by IV aminoglycosides, loop diuretics, anti-neoplastic agents, which are anti-cancer drugs, quinine-containing drugs, and large doses of aspirin can cause tinnitus. Tinnitus is that ringing or burning in the ears. Neural hearing loss is caused by problem with connection from cochlea to the brain. Presbycusis, I hope I'm saying that correct, is on page 392 in the textbook. This is permanent loss of hearing due to damaged hearing nerves. Recruitment, a progression of presbycusis is a loss of sensitivity to soft sounds and a decreased ability to tolerate loud sounds. Otitis media. This common causes of conductive hearing loss, inflammation and infection of the middle ear, presents in 1 out of 3 children. It is easily treatable. Temporary hearing loss may result. If left untreated, permanent hearing loss, rupture of the tympanic membrane, and or meningitis may develop. Table 25.10 shows prescription treatments for otitis media, and this is found on page 392 in the textbook. Table 25.11, antibiotic treatment for otitis media in children, is found on page 393 in the textbook. So the ears have 2 separate functions, which is to hear and govern balance. These functions are not interdependent. One may be deaf and still have perfect balance. One may have perfect hearing and have a disrupted sense of balance. So in summary, anatomy and physiology of eyes and ears. The eyes have a wide variety of treatment modalities that must be handled safely and properly. The ear's functions include hearing and the maintenance of equilibrium or balance. Most ear disorders can be prevented, controlled, or reversed. And that concludes the lecture of Chapter 25, the eyes and ears. There will be a review to follow during a live session.